and post. Exactly. So, welcome. Today we have the third seminar of the Liquid Biopsy Series of Weill Cornell Medicine. This seminar is focused on the natera technology for liquid biopsy testing. It is a test that is clinically available. And to talk more about its clinical application, today we have Samuel Vilchez, that is a medical science liaison for oncology at natera. So let me share slides. All right. Go ahead. Thank you.
Well, thank you very much, Carolina, for inviting me and for allowing me to speak here today. So over the next 30 minutes, I want to give everyone an introduction to how natera is really driving personalized medicine and care. So all right, perfect. So two of the first things that have been driving the field in clinical decision making are the words prognostic and predictive. That stands for, first of all, does it help us determine who is at high risk or who is going to live longer, right? In the case of predictive, does it help us determine which therapy a patient may benefit more or less? For that, we turn our attention to what technology has been widely used, which is in the case of imaging, leveraging CT scans or MRIs, or clinical pathological characteristics, right? Can we leverage a pathology slide and look at HER2 or PD-L1 testing? Does that gives us a sense of the therapy they should be using? Or looking at serum-based biomarkers when we consider a colorectal cancer or pancreatic cancer, right? This has all been very good in terms of driving the field of clinical decision-making. Unfortunately, these do not come without limitations. When we consider these three main tools, what we notice is that we rarely are able to catch these diseases at a micrometastatic level. Unfortunately, as well, the characteristics that we see in the clinic can often be subjective, and the risk features are not always associated with outcomes. When we look into the protein-based biomarkers as well, one of the things that we see happen often is that these are not necessarily related to the disease and can be an indicator of other aspects that are not necessarily cancer. So there is a need for a better approach in personalized medicine, and natera's approach is leveraging these three products in oncology, which we will dive deeper later on, which are mPower, Altera, and Signatera. In the case of mPower, this is our hereditary cancer test for assessing the risk of a person developing cancer. And this is important because we know that 1 in 10 people approximately from the cancer population will develop cancer due to hereditary conditions. What we see on the graph in the right side is that this puts the patients at a much higher risk if they have a particular mutation in that gene, an example of the breast cancer for the BRCA1, and in the case of APC for the colon cancer patients. The test is basically a blood or saliva-based test that can screen up to 81 different genes associated with cancers on the hereditary aspect, and it looks into next-generation sequencing to analyze these samples and find mutations that could inform the patient of what would be the next step. In the case of Altera, this is our comprehensive genomic panel that looks into the tumor profiling for selecting therapy by analyzing RNA and DNA in the sample. Basically, it looks at the sample and it analyzes DNA and RNA from a comprehensive genomic panel approach, and it looks at the clinically actionable mutations, and in particular, over 400 medically relevant genes to be able to detect if these are actionable in the sense of potential therapeutics and potential clinical trials that could inform the patient. This is an example of the report for Altera, where you see in the top column, it has the genomic snapshot of the tumor mutational burden, which allows them to determine which therapy they could go to. It has whether clinical trials are available or not. And it also looks into the list of genomic targets on the left, the list of drugs that have been approved for the patient, and the potential trials that could be benefited from that particular aspect. And then lastly, the focus of today, Signatera, which is looking into molecular residual disease for surveillance and early recurrence detection. We will dive into the Signatera applications, but before, let me take a step back and define a little bit what is the difference of Signatera with the other two approaches that I mentioned. What we see here is that we'll be using circulating tumor DNA for MRD assessment. And again, MRD is molecular residual disease at this time frame for being able to catch disease as early as possible and give these patients a second chance to cure. ctDNA is only a proportion of the total cell-free DNA that's available in the circulation. When we consider this, basically what it means is that almost all cells in our body are going to release the little strands of genetic material into the circulation, and ctDNA is the specific genetic material that is released by cancer cells. The problem here is that this is present in the circulation at very, very low amounts. We're talking 1% or less of the total cell-free DNA that's out there. So even though this was known since the 1990s, we only recently were able to develop the technology to be able to detect it and monitor and act on it potentially. So ctDNA, if we're able to detect it and measure it properly, can serve as a very good biomarker to be able to understand, is there presence of disease at the molecular level, and what can we do to give it a more prognostic and predictive value for these patients. So then the question comes, how does Signatera differentiate itself in the ability to measure MRD? First of all, our approach starts by sequencing the tumor tissue from this patient to look at specific unique mutations that are being able to be tracked over time. And here I want to point the attention towards these blue lines. Wait, let's see. So here I want to point the attention towards the clonal mutations that can be tracked over time, where the patient is able to see these mutations and develop this genetic panel that can be tracked over time without the resistance to therapy or evolution of the cancer progression. Once we select these specific mutations, we look at a custom PCR assay that has the top 16 mutations found, and we develop this panel that can be used over time to monitor this patient in a minimally invasive way. Once they have this panel developed, then we're able to use this personalized test to monitor changes over time and to detect the presence of residual disease. What this means from a clinical standpoint is that we're going to have this report where we see on the top row a very simple positive or negative Signatera result. Then we have a quantitative value of mean tumor molecules per milliliter, which basically allows the patient to observe, and the clinician, what is the quantity of tumor present at the molecular level. And then lastly, we see historical progression of the patient's evolution with cancer, which allows us to track how it's responding to potential aspects in the therapy or surveillance regimes. Signatera as well is good to mention that this is the most widely used and extensively validated assay out there, with over 50% of oncologists using it in the US, over 500,000 tests being ordered today, and it has been extensively validated. We're talking about 120 peer-reviewed publications, and also the one with the broadest Medicare coverage for multiple indications and immunotherapy monitoring. Another thing we see across the board in Signatera is its good prognostic value. And what I mean here is that when we look at multiple indications, it doesn't matter if we're referring to colon cancer, breast cancer, bladder cancer, or so on, we notice that in these Kaplan-Meier curves, basically, we're looking at the y-axis, which is the experiencing an event, the probability of experiencing an event, and in the x-axis, the time that the patient lasted without that probability. And we notice that across multiple tumors, Signatera negative in green, or ctDNA negative, is doing much better over time compared to the ones that were identified as ctDNA positive for these indications, which is the one shown in blue. We also notice that this test is extremely sensitive and very specific, and also provides a lead time of at least 3 months, which gives us a window much earlier than imaging modalities to be able to potentially make decisions on this, or which patients may benefit from actionable outcomes. So when we think about the stages of care, what I want to bring to the attention is how do we leverage ctDNA during this MRD to be able to improve care and make it more personalized today? What we think about in terms of the early stages, when we consider diagnosis and surgery, is can we assess, once the tumor has been identified, is there a chance for an early response or escalating or de-escalating treatment, right? Making sure that prior surgery, the tumor is as resectable as possible. After surgery, is there anything we can do to optimize the treatment that the patient is receiving? What are these scenarios that we can truly identify ctDNA patients and being able to make it a more personalized approach? In the case of surveillance, what we see is that detecting molecular disease earlier allows us to be able to determine which patients should be taken into the clinic earlier for a follow-up or should be just better off without therapy at all and in observation. When we consider the fact of advanced disease as well and looking into systemic therapy, can we monitor treatment for these patients? Can we somehow limit the adverse effects that they are receiving or optimize the dose such that these advanced stage or metastatic patients are not suffering the burdens of these highly toxic treatments? So for today, I want to dive into specific examples for each across indications, just to give a broad sense of how Signatera has helped creating a more personalized approach towards medicine. Looking into the neoadjuvant space, this is basically from the moment of diagnosis right to before surgery. The first example I have is this I-SPY2 trial on breast cancer patients. In particular, these are high-risk stage 2 and 3 breast cancer patients that have been monitored from baseline, that is from diagnosis all the way to surgery, and measure whether the patient achieved a pathologic complete response or did not. Basically, when the patient had surgery, was there any tumor left based on a biopsy or not? In the meantime, in the neoadjuvant space, what you see here is that from the moment it was diagnosed until surgery, the patients are receiving a standard chemotherapy drugs that are hoping to be able to reduce the burden of the tumor. And this particular clinical trial was looking into multiple investigational drugs that could expedite the process and potentially give these patients a better chance to a personalized treatment. What we did with ctDNA is that we monitored the patient's blood at diagnosis, at the beginning of the first line of treatment, after the first line of treatment, and after the second line of treatment to identify dynamics over time. And what we see in this population is that when we monitor the ones that, in this analysis, when we monitor the ones that had higher levels of mean tumor molecules per milliliter, this is represented in the graphs here, the ones in blue. We notice that despite the subtype or breast cancer, whether HR positive, triple negative, or HER2 positive, the ones that had the higher amount of mean tumor molecules per milliliter ended up being more likely to experience an event of recurrence. In fact, if we break it down by actual quantities of ctDNA, what we see is that the patients that were negative for Signatera at baseline, right at diagnosis, and remained so during treatment, were the ones with the best prognosis, the best chance of staying disease-free. We see, in fact, that 96% chance of remaining disease-free during the first 3 years. But this drops subsequently as we start to see increasing levels of residual disease. From 0 to 2, their chances drop to 94% at 3 years. And for those that are above 20 mean tumor molecules per milliliter, what we see is a chance of 69% of remaining disease-free. Now, when we consider the actual clinical trial I-SPY2, what it was looking at was did the patients achieve pathologic complete response or not? What we see here in this curve is that the ones that achieved pathologic complete response in blue for this subtype in the HR positive were the ones that were performing the best. And for a 7-year follow-up, these were the ones that had the best chances at survival. But interestingly, for the ones that did not achieve pathologic complete response, these are represented in green and in gray. We see a very different behavior just because whether they were ctDNA positive or not. For the ones that were negative after surgery, it means that their chances of survival in green were much better compared to the ones that were positive right after surgery, providing an independent prognostic marker of the pathologic complete response that could be assessed as well for this patient population. In fact, the hazard ratio here, which is their likelihood of experiencing the event, it's almost six times as likely for the ones that did not achieve a response and ended up being molecularly positive for Signatera. This is also shown for the triple negative breast cancer, which is the most aggressive subtype. And interestingly, even though in this study we're only looking at one patient, even if this patient achieved pathologic complete response in the dark blue line, what we see is that because this patient was Signatera positive, it ended up recurring within less than 2 years. So looking into ctDNA as an additional marker of the prognostic value can help in this breast cancer population. Now thinking in the surgical time point and after surgery, how can we best improve what is currently done today? For that, I want to turn the attention to a different indication, looking into colorectal cancer patients. And this is known as the Circulate Japan trial. This is one of the largest trials to this day, looking into multiple aspects of the value of ctDNA. First, on top, we have the Vega trial, which is a de-escalation trial. And then we have the Altair trial, which is an escalation trial. But for today, I'm going to focus on the Galaxy arm, which is the observational trial. In this trial, we're looking at patients all the way from stages 1 through 4 in colorectal cancer with curative intent surgery, monitoring them a month after surgery and every 3 months after that to be able to understand ctDNA dynamics in this population. And what we see right away is that if we look at the MRD window, which in this case is defined as 2 weeks after surgery and up to 10 weeks after surgery or at the start of adjuvant chemotherapy, and we look at this population, we have over 2,000 patients that were monitored in this cohort, and we see that across multiple stages of cancer, the fact that they were ctDNA negative after surgery means that their prognosis was significantly better. And we're talking about that if you were ctDNA negative, your chances of remaining disease-free after 3 years are 83%, compared to the ones that were positive with chances of only 16%. So what if we look at the high-risk population? What if we only center in the ones that are at the highest likelihood of recurrence based on the standard factors that are set to date? We see very similar observations. In fact, from this publication, we see that the ones that are ctDNA negative, even though these are the high-risk population, are much less likely to experience a disease event compared to the ones that are ctDNA positive. This is also an interesting figure from this poster, which what we see is basically that for the patients, if we look at the left plot here, for the patients that were represented in blue, this means that from the moment of surgery, they remained ctDNA or Signatera negative. The ones in green are the ones that were positive but turned negative right before the start of adjuvant therapy. And the ones in red are the ones that were persistently positive even after the curative intent surgery. And interestingly, even though there's no significant difference between the ones that were consistently negative or the ones that turned negative in this short window, what we see is that their survival chances are very, very different. The ones that were consistently negative ended up performing much better than the ones that turned negative. And the ones that were consistently positive are the ones that performed the worst in terms of their chances of survival. What this shows is basically that ctDNA is a dynamic marker that we should consider for surveillance and for multiple time points. In fact, even though it was negative at start, this does not necessarily mean the patient gets the full picture. We want to see this recurring negative behavior to make sure that disease is not coming back. And if it was positive at the start, what it means is that the patient may clear ctDNA eventually, and that can give them a very different chances of survival than if they stay persistently positive. So monitoring ctDNA over time provides a very big prognostic value for these patients. Now, what if we put it all together with what we've known from the clinical pathological factors? When we start looking into other aspects such as gender, age, tumor location, or even pathological stage, what we see is that even though these are important factors for determining risk, what is most important compared to all these other factors ends up being if they have a trace of molecular residual disease. Basically, are they Signatera negative or positive within this window? What we see for their chances of disease-free survival is that if they are ctDNA positive, their hazard ratio is much higher compared to any other factor that is shown here. And exactly the same is shown for overall survival in these patients. Now, when we consider again in colorectal cancer, when we talk about the high-risk patients, this is where the clinicians spend most of their challenges because current guidelines, unfortunately, do not give you a clear direction in terms of who to treat at this stage. These patients are early stage, stage 2, but yet they're considered high risk. So it's up to the provider to determine, should they get adjuvant treatment? Should I give chemotherapy? Should I put them on observation? In many cases, what it could happen is that you end up treating these patients unnecessarily, or you end up not treating the ones that you should be treating. So for these early stages, is there a way we could improve these decision-making with ctDNA? And in fact, there is. In this analysis, what it shows is that if you take this high-risk group, early-stage patients, and you observe the ones that were given adjuvant chemotherapy in blue versus the ones that were just observation in red, we see that there's basically no difference statistically for the ones that were negative during this MRD window. And we're talking again, this 2 to 10 weeks prior to the beginning of surgery. So very important to keep track of dynamics right after the surgical time point. But now what happens if the patient ends up being ctDNA positive in this subgroup? What we see is that for the ones that are positive, there is a very big benefit of giving adjuvant chemotherapy. What we see in this study is that the ones that received adjuvant chemotherapy and were positive, in fact, had a chance of survival after 2 years of 53%, compared to the ones that were only proceeded with observation, only 10% chance of remaining disease-free after 2 years. So potentially, Signatera demonstrating the value of adjuvant chemotherapy based on ctDNA. So turning our attention to a separate cohort, now looking into bladder cancer, this particular trial, IMvigor10, was looking into this high-risk population for muscle-invasive bladder cancer, and it was selecting patients based on PD-L1 status, which is usually served as a biomarker for determining who is eligible for immunotherapy. In this particular case, we're talking about atezolizumab, and what we see here is that this phase 3 randomized trial was aiming to select these patients and demonstrate atezolizumab may give these patients a better chance of survival after surgery if we treat them in this particular setting. Unfortunately, the trial failed. It did not show a significant benefit from adding this immunotherapy after surgery, but there was a pre-specified ctDNA analysis that ended up showing that the patients that were ctDNA negative, in fact, did not have a significant difference in terms of how their outcomes were for overall survival. But again, if you look at this cohort that had molecular residual disease and you give them adjuvant treatment, in this case is represented in the line in blue, these do have a significant benefit compared to the ones that were observation only. So by further stratifying based on ctDNA status, these patients may have a second chance to cure in this aspect. So what does this mean then for a later stage when we think about surveilling the patients after the treatment has been done? How can we act on that? For that, I want to turn the attention for the IMvigor11 trial, which actually was inspired by the ctDNA results that we saw in IMvigor10, which is one of the first trials that is based on treating on molecular recurrence, which means that now you're going to take this population and on top of the prior criteria, you're going to divide these cohorts into whether or not these have molecular residual disease. Basically, for the ctDNA positive arm, you're going to randomize them to see if they have benefit from atezolizumab or placebo. And in the ctDNA negative arm, you're just going to do imaging as a means of observing and monitoring and following up with these patients. This is a prospective interventional trial, and it's one of the first kinds for this field. What we see here in this publication last year is that the ones that were ctDNA negative persistently ended up having fantastic chances of overall survival with over 98% at 18 months chances of remaining disease-free just because these were ctDNA negative. And in fact, interestingly, this week, Natera released a press release showing that for the ctDNA positive group, there was a positive readout for benefit of immunotherapy for these patients. And this is the first of its kind demonstrating utility in a prospective randomized sense. Now, when we consider systemic therapy. This is for advanced stage immunotherapy. What can we do with ctDNA in this case? And for here, I want to bring the attention to the INSPIRE trial, which is in fact the one that got the approval of the pan-cancer immunotherapy monitoring, looking into Signatera, developed for a cohort of multiple patients being treated with pembrolizumab, which is a single-agent immunotherapy, across multiple time points. And ctDNA was compared to a standard imaging modalities such as CT scan, and it was measured at the beginning, during treatment, and with follow-on draws afterwards. And what we saw in this cohort of, I believe, 25 different cancer indications is that majority of them had detectable ctDNA at the start. But interestingly, when we look up even as early as 6 weeks during treatment, the fact that a certain population showed a decrease or an increase was already helping divide the population into who may receive benefits or not benefits from this particular treatment. In fact, when we look at progression-free survival or overall survival, we see that the ones in blue are representing a decrease from ctDNA from the start, and the ones in green are representing an increase in ctDNA from the initial point of treatment. Therefore, determining these dynamics are letting you know who may benefit more from this particular treatment as early as 6 weeks. So how can we put it all together? When we think about this from a patient's perspective, I want to bring up this patient case that was published in 2023, where we look into how ctDNA in a commercial setting can help you determine these decisions and make arguments for what could be helpful for a patient's standpoint. And what we see is, in this particular case, I believe this was HER2-positive cancer that the patient was being treated with the standard chemotherapy and ended up showing a good response towards treatment, but ended up having an increase in ctDNA right prior surgery. At this point, surgery was performed, and it did show a pathologic complete response. Again, that means that there was no tumor found histologically, but the provider followed up with Signatera and showed that there was molecular residual disease. This prompted the start of TDM1, which is an antibody-drug conjugate targeted towards HER2, again, personalizing medicine for this case. And even though it was negative on imaging, no evidence of residual disease, the patient did end up clearing ctDNA subsequently, and later on, it showed also no evidence on imaging by clinical exam as well. So giving this patient more reassurance of the fact that the cancer is truly gone, even at the molecular level. Now, what happens when we consider a different scenario? In this case, we have a triple-negative breast cancer patient that was initially Signatera positive and ended up starting this immunotherapy and chemotherapy treatment, cleared early, but unfortunately had to discontinue due to toxicity effects from the therapy, and then ended up going through surgery. The surgery, unfortunately, had residual disease present. This is characterized by nodal involvement and some stages in the, some percentage of the tumor being there, and Signatera positive after surgery as well. The provider saw an increase in Signatera values as well, which got them started on pembrolizumab, and then confirmed the imaging by confirmed the relapse by imaging, which turned to switching therapies for potentially a more effective treatment afterwards. So helping the provider and the patient navigate these complex cases at the molecular level with ctDNA monitoring. So to close, to put it all together, Signatera has been demonstrated, which is the deepest validation available, with over 120 publications, in fact, covering over 90% of all publications out there for the MRD space. Is the most ordered one and has broadest Medicare coverage for multiple indications and pan-tumor immunotherapy monitoring. In fact, this is not our only approach towards personalized medicine. Natera also offers Latitude, which is the tissue-free molecular residual disease test, and Signatera Genome for these aspects where sensitivity can be challenging for particular indications. But please bear in mind that up to this day, these are not yet available commercially in New York. And it also offers what I discussed earlier in the presentation, which is Signatera, Altera, and Empower. With that, I conclude my part of the presentation, and I'm happy to take any questions.
Thank you. you so much. Are there any questions here or on Zoom also?
I had a question.
Yeah.
So in any of these trials where the ctDNA was going up, was it observed that there is chance of metastasis?
So if I understand your question, you're saying that if ctDNA was going up, is there a chance of metastasis?
Yeah.
So what this test was doing basically was looking into the prognostic aspect of ctDNA. And what it shows is if you measure ctDNA positive, what are your chances of the cancer coming back, right? Not necessarily, it could be locally, it could be metastatic at a different site. But what was shown across multiple indications is that if you are ctDNA positive, it basically means it will come back. It's a matter of when, but if you're already showing disease at the molecular level, this will keep progressing with a very high chance of the cancer being at a later stage metastatic or again locally present. So yes, briefly said.
Have you guys tried to look at circulating tumor cells? And if so, have you done a comparison between ctDNA and circulating tumor cells?
That's an interesting question. I think
You work on CTCs?
yeah. Yes, I also work with CTCs a little bit during grad school, but for natera's approach, the foundation is looking into cell-free DNA and circulating tumor DNA. Our bioinformatic capabilities trace back, I think, from 2004, starting in other aspects that I didn't touch on here, so like women's health, organ health as well. Circulating tumor cells may be a bit of a different approach in terms of what we offer, but of course they are related. It's just that by looking at ctDNA at this molecular level, we have been able to develop very strong evidence on the prognostic sense, and recently now showing predictive evidence as well. So there may be research efforts internally. I can look up and let you know, but so far our approach is looking at these strands of ctDNA that are released by cells, including circulating tumor cells.
And I was wondering if you had looked and there was a correlation.
I may need to look into that and let you know, but I believe for now our offerings are mostly looking into if the cells release ctDNA, can we measure that? Whether if it's a CTC, whether if it's coming from the primary tumor, can we detect the smallest traces of circulating tumor DNA that's out there in the blood? Unsure right now if this has been differentiated by whether it's come from circulating tumor cells or the primary tumor.
But if I can add on that, not necessarily the natera test, but I think there is only one study that is published that does both of them. And what they showed is that is not always correlated. So you can have patients that are positive only for ctDNA, not for CTCs, and vice versa. And I think, and this is true also in the metastatic setting, they don't always go together because the ctDNA is more like a proxy of the tumor burden, while CTCs are more a biological process. So of course, you have an increase in CTC number as you go in later stages, but is not that like exactly correlated, because you could have a tumor that release more CTCs and the tumor that just doesn't release a lot of CTCs. So in our group, we think we should absolutely do both of them together. I think the literature data that is out there, at least in early breast cancer, shows that there is a clear prognostic significance of the CTCs also in the MRD setting, but the detection was very low with the cell search. That was the technology that was used for most studies. Right now we are doing a study using a different technology that doesn't do the enrichment of CTCs, and we are seeing much higher detection of CTCs. Of course, we have to wait and see if they are correlated with prognosis, and we will for sure correlate it with the ctDNA detection.
Yep.
Did you guys look if there's any tumor intrinsic factors such as infiltrated immune cells or a specific molecular signature that's associated with increased release of ctDNA?
So basically, you're asking if there are any tumor-specific factors like inflammation signatures or immunology signatures that may affect the release of circulating tumor DNA?
Yeah.
That's a very interesting question, and I think we haven't done that yet, to my knowledge. But one thing that we have shown is that despite these factors, right, like whether the inflammation profile, the risk profile, the immunology profile, if this patient is releasing circulating tumor DNA, their prognosis is going to be much worse. I'm still fairly new in the company, so I can look up and see if we have done such analysis. But what is certainly like very compelling evidence across indications is that despite your stage, despite your inflammatory response, despite any other biomarker that is typically used in the clinical context, if you are releasing ctDNA, you are going to be at a much higher risk of the cancer coming back. Yeah. Yes.
So if I understood correctly, for the assessment of ctDNA, you guys first sequence the tumor sample, the tissue, and then with the more relevant mutations, you create like this PCR that you apply to your ctDNA. I'm wondering if when you look into the mutations, you focus on the clinical actionable ones or any type of mutation that you might find?
That's a great question. I didn't dive into that now for purposes of time, but basically, what differentiates Signatera's approach is that specifically. When we look at the tumor sample and we do the sequencing there, we do the whole exome sequencing, we take a look at the top 16 clonal mutations that are not driver mutations. And this is because that way we can make sure that we're tracking the most reliable mutations for this patient uniquely across the evolution of the tumor, despite heterogeneity, despite progression, despite metastasis, and despite treatment. If we pick actionable mutations, these may be gone afterwards, and we may not have a very good sense of whether the tumor is there or not. We have done studies across multiple indications as well, looking into that specifically. And what we've shown is that at least 90% of the clonal mutations stay throughout the evolution of the disease. And since we look at the top 16, we have a very high chance of being able to target these patients' molecular burden over time, despite when Signatera is created, and also with very high accuracy as well, because we focus on mutations that are not going to fade away.
And do you compare with the healthy tissue of the patient? Because one of the questions that I might have is that you might, with age, you might accumulate mutations that might not be actually involved in the mutagenesis process. So I don't know if that could impact the sensitivity of the assay or not.
That's another thing I couldn't dive into because of time, but we do, right? We match these samples to normal blood so that we can exclude germline mutations. We only care about somatic ones, which are the ones that are coming from the patient's cancer. And that way we can also exclude CHIP mutations, which are clonal hematopoiesis of indeterminate potential. Looking into these mutations, to your point, that happen through age and that are related to just like the fact that you have DNA present in your blood that goes through particular changes that may not be cancerous. So by matching it through normal blood, we're able to exclude all those that are not related to the patient's cancer. Thank you. Thank you for the questions. Any other questions?
Also on Zoom, if you have a question, just open the microphone and ask the question.
We have a quiet audience.
Yeah. If not, we can move forward with the next presentation, but Sam will be here after the seminar to discuss if anybody here wants to discuss. And for the people on Zoom, I'm sure he will be available if you are interested in talking more about the natera testing. You can contact me. I can put you in contact or you can find me sure also. So thank you again.
Thank you for coming.
And as is the tradition of this seminar series, now we will have a short presentation of an example of how we are using the natera data to do research in the liquid biopsy team here. And so Hunter, that should be on Zoom. Hunter, yes, here he is. He's a PhD student that recently started working in our lab under the mentorship of Dr. Cristofanilli and also in collaboration with the team of Dr. Elemento. And he will present some preliminary data on a study we are conducting in collaboration with Natera focusing more on the in the MRD setting, but focusing more on the data derived from the whole exome sequencing performed on the primary tumor. So Hunter, you can share your slide.
Yep, sounds good. All right. Yeah, you can see the slides?
Yeah.
Yes.
Okay, great. Yeah, so thank you, Carolina, for the introduction. I am going to discuss a little bit about some whole exome sequencing data that we have acquired from Signatera's ctDNA tumor-informed test. So, yeah, so data from whole exome sequencing of the primary tumor can be integrated into the management of patients with localized breast cancer. So here we are showing a study that was conducted through our group and collaborators. And it's the first to incorporate whole exome sequencing data with tumor-informed ctDNA analysis to evaluate the impact of targetable genomic alterations on ctDNA detection. So the study found that 44% of patients with ctDNA positivity had at least one targetable genomic alteration in the whole exome sequencing data, with PIK3CA being the most common. And interestingly, among patients with ctDNA positivity, those with PIK3CA mutated tumors tended to have worse outcomes than those with PIK3CA wild type tumors. So now we're looking to expand this analysis with a new data set. And instead of focusing solely on therapeutically actionable mutations, we're interested in evaluating the differences in the full mutational burden between patients with and without eventual ctDNA positivity. Also, in localized breast cancer, there's an unmet need for reliable predictors of pathological complete response to guide personalized treatment and surgery after neoadjuvant therapy. So we're looking to use the same whole exome sequencing data set to investigate the mutational profile differences between patients who achieved and did not achieve PCR. So again, just to summarize the aims, we're looking to evaluate the impact of genomic alterations on both ctDNA detection across breast cancer subtypes, and also on patients that achieved or did not achieve PCR after receiving neoadjuvant therapy. So, sort of snapshot of where we are. This is really a feasibility demonstration as we have just transferred 31 patients, the whole exome sequencing raw data from that was acquired through the Signatera workflow. The total cohort currently is 89 patients and growing, with a total of 318 longitudinal liquid biopsy tests in that data set at Weill Cornell. And so for these patients, we've done quality control and pre-processing, somatic variant calling with complementary pipelines, consensus filtering, and then downstream analysis. And then here we have a table of the patients broken down by stage of diagnosis, by subtype, and then showing which patients did receive neoadjuvant treatment, and of those patients, which achieved pathological complete response. So again, this is just a feasibility study. There's not much statistical power given the small sample size, but just showing the type of analyses that we'll be able to do. This is an oncoplot of the entire cohort showing that there are alterations of the classic breast cancer driver mutations in 74% of patients. We see that TP53 and PIK3CA are the two most frequently mutated genes, which is in alignment with previous studies and known literature. And then we see, in alignment with AIM-1, breaking down these oncoplots by patients that were ctDNA positive versus ctDNA negative. So ctDNA positivity was defined as having a positive Signatera test at any time point. We see here, again, small sample size, but 100% of ctDNA positive patients had alterations in classic breast cancer drivers versus 68% for ctDNA negative patients. We see higher mutation rates of TP53 and PTEN in the ctDNA positive subset. And interestingly, 32% of ctDNA negative patients did not have alterations of classic breast cancer driver mutations, which could suggest unique mutation profiles that could be explored further. Here we're just showing a gene-centric mutation map, in this case for PIK3CA. And this is stratified by ctDNA positivity. Again, small sample size, but just showing the type of gene-centric analysis that we'd be able to do on the whole exome sequencing data. And in alignment with AIM2, here are the oncoplots broken up by pathological complete response. And this shows the tumor mutational burden, mutations per megabase in both the ctDNA group and the PCR group. Again, no statistical significance at this point, but showing the type of mutational profiling differential analysis that we hope to conduct as soon as our patient size grows. And so just to summarize and briefly discuss potential next steps, this was really just to demonstrate feasibility as we were able to successfully process and analyze the whole exome sequencing data from 31 primary breast tumor samples. The cohort is quite heterogeneous, which is both very valuable and also presents some limitations in the requirement for additional samples. But our patients span multiple stage of diagnosis and include all of the subtypes. We found that the driver landscape is consistent with prior reports thus far, seeing TP53 and PIK3CA emerging as most frequently mutated genes. And then we're also seeing some potential trends early on in both the ctDNA positive and negative and the PCR groups. But again, these are not statistically powered. And so then the next steps would be first to increase the sample size, which would then enable us to stratify across subgroups and do additional analyses. And then moving on to pathway level analysis as opposed to just gene-centric analysis. So I'd just like to thank members of the Cristofanilli lab, the Elemento lab, and the Natera team, specifically Carolina, Eleonora, Breno, and Bob Neat for help with the work thus far. And I'd be happy to try to answer any questions.
Thank you. Any questions? Nothing? Of course, these are very preliminary results, so yeah, we
And
need
this kind
to...
of answer the question that you did before. With this analysis, we are trying to understand who are the patients that are going to be ctDNA positive, because if you know that from the very beginning, from the time of the biopsy, you can change the whole treatment of the patient. So this is the goal of this analysis.
Yeah. And I'm sure we will expand this to the whole cohort of breast cancer patients that we processed so far. It just started, but also if anybody working in colorectal cancer is interested, we have the data transfer agreement also for that. We did it. Nice. We never started the analysis because we are focused mainly on breast cancer, but if anybody's interested, contact me and we could do some similar analysis also for colorectal cancer.
I had a question in general. So yeah. It's like if we see the ctDNA, like the sequencing tells us that the copy number changes or anything like for different genes. Like, so that does that tell us that, okay, the treatment is going in a right direction, or we always have to compare it with the primary tumor? Like I'm trying to say the RB status or any other like gene status, so their copy number and everything. So does the ctDNA itself is a predictor, or we always have to go back to the tumor?
No, I think as Sam was showing already in itself, monitoring the positivity to ctDNA is an indicator of treatment response and of prognosis. What here it's a bit different. Like we would like to be able to predict that at the moment of diagnosis, which are the patients that are more likely to have ctDNA positivity and why? What are the characteristics of the tumor that are associated with that ctDNA positivity post-surgery or with the PCR? So it's a bit different, but I think the ctDNA assessment per se can be very useful in the clinic to monitor and to predict. Okay, but if there are no more questions,
Thank you.
thank you so much to our speakers. Thank you to all the audience. Just another reminder that this seminar is being recorded and will be published on YouTube and on the Liquid Biopsy platform website. And stay tuned for the next seminar. Thank you.